Hello, and welcome to the webinar on progressive familial intrahepatic cholestasis, also known as PFIC. We are happy to have you with us. I am Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Liver Health Foundation is a patient advocacy 501c3 nonprofit organization representing millions of liver patients in California and beyond, with the mission to support liver patients, their caregivers, and family members. Tonight's webinar is about a rare liver disease commonly known as PFIC. Rare diseases are those which impact a small number of people when compared to the general population. For example, in the United States, a disease is categorized as rare if it affects between 200,000, around 200,000 or fewer than 200,000 people. At present time, there are about 7,000 different diseases are recognized as rare, and they affect about 400 million people worldwide. Rare diseases, also known as orphan diseases, simply to highlight the lack of effective treatments, research, and drug development efforts. The goal of tonight's webinar is to shine light on PFIC, which is mostly known by an intense itching sensation. We are honored to have some of the best hepatologists with us. Please remember, information given to you by our experts is not a substitute for advice from your own physicians or healthcare providers. We do not endorse doctors, hospitals, medical centers, or treatments. Tonight's program has been made possible by an educational grant from Epson Biopharmaceuticals. We thank Epson for their support and their efforts in the rare disease area. It is now my pleasure to introduce Dr. Robert Gish, who has generously accepted to be the presenter for tonight's program. Dr. Gish is Adjunct Professor of Medicine, University of Nevada, School of Medicine, Las Vegas and Reno, Adjunct Professor of Pharmacy, University of California, San Diego, a Clinical Professor of Medicine at Loma Linda University, a staff physician at Loma Linda University's Liver Transplant Clinic in Las Vegas, Medical Director of the Asia Pacific Health Foundation in San Diego, and the Medical Director of Hepatitis B Foundation in Doylestown, Pennsylvania. Dr. Gish attended pharmacy school at the University of Kansas and subsequently obtained his medical degree from the University of Kansas Medical School in Kansas City. He completed a 3-year internal medicine residency at the University of California, San Diego, and a 4-year gastroenterology and hepatology fellowship at the University of California, Los Angeles, which included transplant medicine. Dr. Gish is a fellow of the American Association for the Study of Liver Disease, the American Society of Transplantation, and the American College of Physicians. He has served on the editorial boards of American Journal of Gastroenterology, Hepatology, Journal of Hepatology, Digestive Diseases and Sciences, and Gastroenterology, among many others. He has co-authored a public health policy for liver health in Vietnam focused on HBV and is also assisting with the development of viral hepatitis healthcare policies in Georgia, Armenia, and the Philippines. Dr. Gish was a major early contributor to decipherment method for the detection of Hep B and C virus and categorizing its epidemiology and clinical presentation in humans. He was involved in studies that led to the genotype classification strategies and methods now in use worldwide. He has published more than 700 original articles, review articles, abstracts, and book chapters. Dr. Gish currently is seeing patients both in person and via telemedicine at various clinics in San Diego, Folsom, San Jose, Santa Rosa, Las Vegas, Reno, and via telemed to you. Dr. Gish, thank you for your support and participation. We really appreciate your support of our efforts in this area and reaching out to patients. We are ready for your presentation.
Thanks, Vera. That's great. I've got to figure out how to make that 3 times shorter. You're way too kind. But and there's been a few updates. Number one is it's now the American Pacific Health Foundation from Asia Pacific in San Diego. So we're quite busy doing healthcare events in San Diego and collaborating in Orange County, LA, and San Francisco with viral hepatitis and liver health screening. But let's get to the meat of the meeting tonight. And what we're going to do is talk about genetic cholestasis. And we're definitely going to have some chats about PFIC in here, but I really want to build out a much bigger story. And these slides are pretty sophisticated, Farah, so I apologize, but I'm going to go both basic for the patients and providers that are online and also advanced, because I know there's a number of physicians online also to listen to this. And I think both perspectives are extremely important. And of course, the patient's always number one. I'm going to try to build the story around why these advances are very important for our patients. So we're going to talk about cholestasis in general, and then we're going to talk about PFIC. And by the way, just for everybody's education, there's 11 different forms of PFIC right now that have been identified, and I'm sure there's more to come. We're going to talk about genetic testing because we are in the genetic age and genetic era, and there is a special panel, a cholestasis genetic panel available through Prevention Genetics. And that cholestasis panel looks at 77 different genetic changes, or what we call polymorphisms. I found it quite useful. I've ordered it on 22 patients, and 20 out of 22 have had something specific on their genetic testing that helped me with their diagnosis and their management. And Dr. Yanni will be on as my partner in this presentation, covering more of the pediatric issues because I'm an adult hepatologist. But I definitely see that we are a team, and it's really important to help manage our patients together. And one of the biggest issues is itching. Well, I'm going to flip back and forth, itching, pruritus, itching. But this is an incredibly important part of quality of life and what therapeutic options that we have today. So first off, this word cholestasis. I've learned a lot in the last year and a half about this and really changed how I perceive this, even though I've been a hepatologist for 30 years. When we think of cholestasis, we think of high bilirubin. Remember, bilirubin is a liver function test. Alkaline phosphatase and GGT are not LFTs. They are not liver function tests. They are liver enzymes. But a high alkaline phosphatase with or without a high GGT indicates cholestasis, or high bile acids. Bile acids are another liver function test. Our body produces, clears, reabsorbs bile acids and balances those. Some are toxic and some are beneficial in this bile acid world. And bile acids almost act like hormones sometimes. So think about this in terms of cholestasis as we bring this forward. I didn't put itching on here because that's more of a symptom. But now we're talking about blood tests that help us with this. And of course, you could see cholestasis on a liver biopsy. We'll talk about that with one of our cases. So this walks down that cholestasis family a little bit further. And primary biliary cholangitis, PBC, or PSC, primary sclerosing cholangitis, are two forms of cholestatic liver disease that are actually autoimmune. We're going to come back and talk about genetic disorders such as PFIC, progressive familial intrahepatic cholestasis. It's a more severe form in some patients, in some children, of this cholestatic liver disease, and it depends on what genetic variant is there. PFIC1 is 1 out of 11, and that's about 1 in 50,000 births. But if you put all 11 of these together, or you look at the entire family of these cholestatic genetic disorders, I'm calculating it's down to probably about 1 in 3,000 people. We're going to talk about this alphabet soup. I'm not going to go into great detail, but Farah, this slide deck, which I have sent to you, I would say share out to anybody who wants it, post it on your website. It's going to be posted on my website. So we are going to have this as an open dialogue, so I don't have to dig too deep in all the letters and, again, the alphabet soup.
Thank you.
It's great. Yeah, I think that all slides should be shared. That's my philosophy. So very simply, you're looking at two boxes together on this slide with a little doorway in between. The boxes on the right and left are liver cells, and that little doorway is called the bile canal or canaliculus. And into that canaliculus, moving things in and out of the bile between the bile space and those liver cells. And in this case, we have biliary epithelial cells that are part of the liver. We have hepatocytes and bile duct cells that line the bile ducts that are involved in this transport process. And again, here's some of the alphabet soup here: PFIC1, PFIC2, PFIC3, and these little letters tell you what's missing. What is the transporter that's not working correctly? And it might be not moving bile acids. It might be not metabolizing bilirubin or moving bilirubin. It might be not moving what are called phospholipids. And phospholipids make up the membranes in our bodies that keep us healthy and normal. So when you're not moving things correctly, you can get liver disease and you can get itching. Two major issues. This goes a little bit deeper. We talked about GGT as a liver enzyme. It's not a liver function test. And in PFIC1 and PFIC2, the GGT can be 6 or 8 or 10. Normal's around 30 or 35. And these can have onsets right at birth, early infancy, late childhood, adolescence, or now, adults. We're learning that these adults we see in our clinics with cryptogenic or hidden liver disease can end up having one of these genetic mutations and be at risk for progressive liver disease and itching. Itching changes their life today. Progression to cirrhosis changes their life in 5, 10, or 20 years. Now it says cholelithiasis. Let me translate that to gallstone disease. But more importantly, these gallstone disease can be in the bile ducts, not just in the gallbladder, the bile tubes, and be up in the liver itself and cause cholangitis and cause infections. Then, of course, if people have chronic liver disease, they're at risk for different types of cancer. It could be liver cancer, HCC, or CCA, which is cholangiocarcinoma. So it's very important to diagnose this, manage it, monitor, surveillance, and really be aggressive. Aggressive meaning see everybody twice a year, get liver scans once a year if you're not sure what direction the patient is going. This is a patient who first had cholestatic liver disease signs and symptoms at age 20, abdominal pain, pretty early for gallstone disease. They waited till around 35 for a cholecystectomy, which is unusual because surgeons usually take out the gallbladder at the drop of a hat or a scalpel. But this person waited, but no one really thought much of it. Oh, it's a gallbladder. Everybody has gallstones. And at age 60, the patient presented with really high liver tests, high serum bile acids. And I will bet something happened at age 60 that triggered this. Could be medication, could be a virus or something that brought this out. But clearly, this person had a genetic disorder and presented much earlier in life with manifestations of this genetic disorder. But of course, we have to rule out viral hepatitis, different types of autoimmune diseases, which we can do with either blood tests or a biopsy. And this person didn't fit any of these profiles. So the person was smart who was taking care of them, definitely ordered this genetic test, found out they had this ABC change called B4, which is this MDR or multiple drug resistant transporter defect. And it's called low phospholipid cholelithiasis. So we're not making enough phospholipids, the gallstones form and cause disease. So this is a late onset, but this can happen at any time. And if something's atypical, the standard of care today is get these genetic tests done. And then if you need help interpreting them, call your local best pediatric hepatologist. And I've got my 3 favorites in California. It's Kathy Schwartz in San Diego. There's some great people in Los Angeles. There's some great people at Stanford, at UCSF. So we definitely have a whole army of people. I'm biased to San Diego because that's where I live. But I've got other people nationally, Ron Solcall in Colorado. And in North Carolina, we have Saul Carpin. And these are people that we can use for resources. So this is just looking at a group of people that had some type of atypical liver disease. Somebody did genetic testing. They only did genetic testing for 3 genes that really have a lot more to go. And about 1/3 of these patients had an abnormality in their genetics that explained their liver disease. So this is pretty common, especially if you've got somebody you can't explain what is going on. Now we got a little younger person, 28-year-old woman, elevated liver enzymes, not function, liver enzymes, and normal at physical exam, has medical history, said, oh my gosh, these enzymes have been there for a while, right upper quadrant pain, fatty liver. Of course, we have so much obesity in our society now that fatty liver is common, 100 million people with fatty liver, and then had biliary sludge. Little elevated liver enzymes are there, but then this individual got pregnant 2018 and had itching. Well, there's a big trigger. Somebody was smart. They did bile acids, a liver function test, and were diagnosed with high bile acids and intrahepatic cholestasis of pregnancy. High bile acids persisted and they had an early delivery. After delivery, typically the itching resolves, but this person continued to have itching, bile acid binding resin, cholestyramine, which I don't like because my patients don't like it. And they said, oh, we're going to take out the gallbladder. That'll take care of the itching. No, itching continues. And the labs are here showing, interesting here, some liver dysfunction. The best liver function test, of course, is a bilirubin, but the best of the best is getting a conjugated or direct bilirubin. You want to follow how the liver is doing from a function perspective. Direct bilirubin or conjugated bilirubin is your friend. High enzymes, ALT, AST, and of course, if you're a good liver doctor, you're going to get a GGT on every one of your patients. It's part of like the table or the chair. You got to have 4 legs, AST, ALT, GGT, and ALK-Phos. This person had an alkaline phosphatase of 197, which is about double normal, but normal albumin, which means some preserved liver function. The white count and platelets really didn't help in this situation. Everything that was done as standard workup was negative, but the patient had an ultrasound that looked at were there any common bile duct stones or any stones in the liver, none seen, and of course the person's gallbladder was out. They got a liver stiffness measurement. This is a diagram of something that will come out of a fibroscan. It also measures fat through what's called a CAP score. So the fat was normal, liver stiffness was normal, so no major signs of liver damage at this point. But obviously this person's not going to be happy with this ongoing itching that's there. So some did genetic testing, and we will get back to that in just a moment. When you order a genetic test, you really don't have to think about how they're doing it, but we have different versions, including a relatively cheap system called whole exome sequencing. It's cheaper and gets you most of what you want instead of sequencing the entire genome. Now, what happens, and this is what happened, Farah and Dr. Yanni, on the different patients I sent, 22 so far, 20 came back, and most of the ones that came back, the genetic panel said, we don't know how to interpret this, indeterminate. Well, that doesn't mean much to me. I had to go online, I had to do a search, I had to call my different ped hepatologists that I use in my practice. And they said, oh yeah, that's classic. That's going to cause cholestatic disease. That's going to cause some change that got high liver enzymes. So these variants, typically, if you do homework, are going to be associated with cholestatic liver disease, especially when you have 2 or 3 genes that are different. Homozygote means you have 2 abnormal genes, paired. Heterozygous means you have 1 abnormal gene here, a different one there, maybe a 3rd or 4th one. And these directly or through modification can cause elevated liver tests, cholestasis, high bilirubin, liver damage, and to the patient perspective, itching. It's a huge database, and that's growing. And every time you order one of these through Prevention Genetics, those individuals will have that data submitted to a database. So we're going to learn from this, although I'd like more direct learning, of course. And as you heard, well, 3 PFICs, then there were 4 PFICs. Now there's 11 different forms of PFIC. So we have to know what they are, what they can do, what the variants are. And is it itching? Is it quality of life? or is it progressive liver disease, or both? Timely genetic testing is now. It's today. If you don't understand what's going on with the patient, they don't fit a classic liver disease profile, it's time to order this panel. This is what the website looks like, a 77 gene testing panel, and they've got some different user profiles you have to set up. How do you get your kit? The kit will be delivered usually within 2 days, although recently they had a shortage. It took me 6 weeks to get it up in my Santa Rosa office. They get their blood drawn at a local blood draw stations. Somebody there puts it in a box, mails it in, and then because you have an account and you're tagged to that account and you fill out some paperwork that goes with it, you're going to get this back through your website. And on the right side is all the different genetic mutations. And I have seen on this list over 18 different versions of these genetic tests. And they do check for Gilbert syndrome. Many people call it Gilbert's, but that's not correct. Gilbert was British, so he would like to be called Gilbert. And Gilbert syndrome was picked up on here because it may be a modifier. It's not a disease, Gilbert syndrome, but it could modify the manifestations of cholestasis, of course. So here's an example. Person comes back. This individual we just talked about before had this ABCB4. There's a box saying how it's inherited. Then there's a box talking about different variants. And then there's a ClinVar, that's the database that we're talking about. It says not listed, but that may be just because the little number on the left side is not listed, but ABCB4 is definitely in that database. And then on the right side, it says, well, what can happen? And this says damaging. So that basically means it's pathologic. But this person was heterozygous. They had one gene, not two genes. And why are they manifesting? Well, I'm going to say this person probably had some other polymorphisms that are called compound heterozygous that double in two different places that led to the clinical manifestations. Now, here's another cartoon that's kind of sweet. It gets us a little bit higher in terms of where we are. And you can see this interface between the liver cells and the canaliculi, the canal that carries bile out, micelles with phospholipid and cholesterol. And that's in there. And of course, there's bile acids that are in here. And you can see what's being carried in the little box in the upper right-hand side. The liver is very complicated. I often described it doing 200 things every day, and that's probably less than reality. But it's these carriers that keep you and I healthy, keep us not from itching, keeping us from not being jaundiced, keep us from not getting progressive liver disease. They balance bile acids, the good and the bad, so we also can stay healthy. I've seen all of these different variants in my patients so far. I've had each one of these. It's actually denoted on this cartoon. Here's a little bit more information that you can look at later. So the left one is this low phospholipid syndrome. The next one on the right is intrahepatic cholestasis of pregnancy. Gives you just some more details on how people can present. And what's the first line treatment? It's urso. Urso is named after bears, bear bile, and that is a liver flush. It changes the immune system in the liver just a little bit, changes from damaging bile acids to beneficial bile acids or anti-inflammatory bile acids. And down at the bottom, you have to be thinking about other diseases, and you're going to work out with your provider, your partner, your gastroenterologist, your hepatologist. So this is a really important issue. Anytime I see a patient, of course, I'm an adult hepatologist that has a history of cholestatic liver injury. They took Augmentin, they took nitrofurantoin. There's a variety of different medicines that are associated with this cholestatic liver injury. And I'm checking genetic testing on all of those patients. Number one is, do I need to follow them more closely after their drug injury to their liver resolves or appears to resolve? And also, if they have a genetic abnormality, I need to warn them there's a family of medications, 30 or 40, that are classic for causing cholestatic liver injury. And if they are proposed to take one of those medications, then they need to be cautious. They need to be monitored. Their provider needs to know that. So another place to do genetic testing is drug-induced, medication-induced cholestasis. I think that's super important. This is what's called a spectrum. What are the genetic changes you might see in a patient with ABCB4? This is one of the PFIC abnormalities. And this is just a complicated slide that says everybody's special and everybody's different. How they present, what are their enzymes? Do they present with stones? How young are they when their gallbladder comes out? So basically, the big picture here is if you don't understand what's going on, it's time for genetic testing. We do liver biopsies in these patients typically early because we want to make sure they don't have some type of autoimmune liver disease where the immune system's attacking the liver and they might need some type of immune suppressant. And of course, everybody with abnormal liver tests gets at least an ultrasound, and they may move to a CT or MR, which is in the right-hand box, that might identify what's going on in the liver structurally. So biopsies and imaging, very important. This is a whole story about people having this MDR version of PFIC and presenting at different times of their life, from basically when a baby's born to adult onset disease, like our first case when that person was 60 years of age. So I'm going to do genetic testing in all of these different settings. Let me walk through this as we're getting towards our half-hour point. On the left side, cholestasis that you can't explain. The next column over is cholestasis with itching. There's something called small duct PSC. This is PSC, primary sclerosing cholangitis, when the MRCP, an MRI that looks at the bile ducts, is normal. You do a biopsy, the pathologist says, oh, it looks like PSC. That's probably a genetic disease. Primary biliary cholangitis is defined by a positive AMA and high alkaline phosphatase that looks like PBC, but their AMA is negative. Genetic testing. Fatty liver usually doesn't present with itching. So if someone's got fatty liver and itching that's more than a 3 or a 4 on a 0 to 10 itch scale, I'll do genetic testing. Lean fatty liver, somebody who's got a low or normal body mass index, they don't have metabolic syndrome. I'm thinking I'm going to order genetic testing there as well. Then we have this issue of drug-induced cholestasis, medication. It could be estrogens, could be other types of hormones that could be there. And of course, any intrahepatic cholestasis of pregnancy, that's a trigger for this itch phenomena and this liver damage that's there. And on the far right, early gallstones, complicated gallstones, stones inside the liver in the common bile duct. Back to the panel, just to remind people, you can go to the Prevention Genetics website, register, get that box delivered to you. What about itching? This is a huge issue in the pediatric population, and Dr. Yanni will get to that in a few moments as I wrap things up. People can be irritable, sleep deprivation, skin damage, not doing well in school. It disrupts not just the patient's life, but the caregiver, the family, causes all sorts of distress and consumes a lot of emotional, financial, and time resources. So what do you do for this? Well, URSO, very simple. But if the itching is really severe and terrible, we have 2 medications called IBAT inhibitors, ileal bile acid transport inhibitors. You take this medicine by mouth, liquid, or a capsule tablet that goes into the intestinal tract, and it blocks the bile salts from coming back into the body in the lower part of the intestinal tract. We have 2 of these that are FDA approved on the market now. One is called Odevixibat, that's made by Ipsen. The other is Maralixibat, made by Mirum. These are very effective. The itching can melt away within days. And the other interesting thing, which is not in the label, but it's in my interpretation, is that these medicines, by rebalancing bile acids, can slow down, halt, or potentially even reverse liver damage, because these toxic bile acids are bad. Now, we have a whole family of other medicines we can use for itching. If you go to my website, robertgish.com, there's a whole worksheet. It's level 1, level 2, level 3, how you move through there. And then we could do something very radical. And Dr. Yanni will talk a little bit more about biliary diversion. That's one of the questions I think that will come up today. And you can just replace the whole liver. And replacing the liver, Dr. Yanni, which you'll get to in a few moments, does that cure the disease, or can the new liver be affected by what's going on because of these transport defects that might be in other parts of the body? You have to balance nutrition, replace vitamin A, D, K. Those are the three big fat-soluble vitamins where we need bile acids. This just goes into a little bit more of a cartoon. Where do these IBAT inhibitors work? You can see the two chemical names that are on here and where they work in that distal part of the intestinal tract. So take a look at that diagram in the future, but this tells you how they work and how they can change quality of life and how they can change itching by then changing quality of life. You can see this decrease in the itch score as the red line goes down with odevixibat. Then we're moving from a placebo and kind of the gray-green to more of the turquoise, a big dip in that itching score. And this means better quality of life, better sleep, better for the family if it's a pediatric, better for the family if it's an adult. Super important. This is just a little bit more, a little bit of a cartoon with some brand names that are on here. This is maralixibat, one of the other medications that's approved for itching. And this goes into a little bit more of the cartoon. So I'm going to skip over this and hang on just 1 second. I think we're almost at the end. Hopefully I'm not going backwards. So just to wrap things up, cholestasis is this big family. Inside the cholestatic liver disease, the big ones we think about are PBC, PSC, drug-induced cholestasis, then this family of cholestatic diseases where PFIC is 11 of them. But remember, we have 77 different genetic changes, including cystic fibrosis. That's a gene mutation that can result in cholestatic liver disease. There's a variety of other more rare and unusual cholestatic liver diseases that are out there. Think about genetic testing. We've got some really good medications now that are called IBAT inhibitors that can block that bile acid uptake. Urso is your first line. It's widely available, standardized therapy. Some people it works, gets rid of the itching, improves the liver tests, but have a low threshold to use our new IBAT inhibitors for both pediatrics and adults. Farah, Dr. Yanni, Liver Health Foundation, thanks for all your great work. And I think we have time now for some Q&A. Hopefully that was okay. There's a bunch of other cases in here, but we're not going to go through those for this time. I'm going to stop sharing and get back to these beautiful pictures.
Thank you very much, Dr. Gish.
Thank you, Dr. Gish. Very informative presentation. I love the way you broke down all the information that is so confusing to us who have not had medical training. We will now start the second half of the webinar, the roundtable conversation with our guest speakers. They will talk about PFIC and respond to a question. Now, even though I have some questions that I had received and have submitted them to our presenters, our chat function and Q&A tab are available, so you can put your questions there, and Dr. Yanni and Dr. Gish will answer them. It is my honor to introduce George Yanni, MD, FAA, SLD. Dr. Yanni is Professor of Clinical Pediatrics, Director of Transplant Hepatology Fellowship Program, Associate Director, Pediatric Liver Transplant Program, Division of Pediatric Gastroenterology, Hepatology, and Nutrition, Children's Hospital, Los Angeles. Dr. Yanni graduated from Ames Shams University College of Medicine at Cairo, Egypt. After completing his internship in pediatrics, he continued his residency and fellowship in pediatric gastroenterology at Kaiser Permanente Medical Center, Los Angeles, and University of California, Los Angeles. Dr. Yanni has been medical director and associate professor pediatric GI at Loma Linda University Children's Hospital, attending pediatric GI at Riverside County Regional Medical Center, clinical associate professor pediatric GI at Keck School of Medicine, University of Southern California. Some of Dr. Yanni's other titles include Interim Medical Director, Transplantation Institute, Loma Linda University, Adult Liver Transplant Program, Hepatology Fellowship Director, Pediatric Gastroenterology, Children's Hospital, Los Angeles, and Director, GI Endoscopy Services, Division of Pediatric Gastroenterology, Hepatology, and Nutrition, Children's Hospital, Los Angeles. Dr. Yanni's major areas of research and interest are pediatric liver disease, gastrointestinal and hepatic autoimmune disorder, transplant immunology, pediatric NAFLD or obesity, pediatric gastrointestinal procedure. Dr. Yanni, welcome to our program. We are happy to have you with us. I'm not sure if your camera is working.
Do you hear me, Farah?
Yeah, I hear you, but I don't see you.
Yeah, unfortunately, I apologize. There's some technical difficulty with my camera, but thank you very much for this wonderful introduction. Thank you, Dr. Gish, for amazing presentation. I'm going to have a big difficulty to follow up on this the excellent and up-to-date information. I thank the committee and the panel.
Dr. Yanni?
Yes.
This is a place where we are going to start answering some of those questions that I had sent you.
Sure.
I have received a question. I'm not sure if it's a question or a comment, but this is really fascinating. I find it fascinating. So I'm going to read it and ask you to comment on this as well as Dr. Gish. The patient has written, I don't understand why doctors suspect and check for liver connections sooner on the onset of the PFIC disease. I was diagnosed with PFIC after many other tests, living and dietary changes and everything else. My doctors told me not to scratch. It is easier said than done. I have scars on both legs. It felt like ants were crawling under my skin. I tried to stop scratching, but was not very successful. 5 years after I was diagnosed with PFIC, I was told I have developed cirrhosis. Now I'm dealing with that and PFIC. Dr. Yanni, would you please comment on this patient situation? I had reached out to the patient to find out what version of PFIC he has, but unfortunately hasn't responded yet. So please make comments on this.
Do we know how old is the patient?
No, it appears to me that he is in his teenage years, maybe 13, 14.
Well, I think Dr. Gish very, very clearly explains this in his presentation. And please, Dr. Gish, come up forward and interrupt or comment. As Dr. Gish said, when we evaluate patient with liver disease, we have to follow a pattern, and we cannot leave things like dangling behind or unresolved. So most of these the symptoms or itching are associated with abnormalities in the blood test or the liver test. There is a trend over the last 20 to 30 years from the primary doctors or the primary providers not to investigate or not to ask for testing, which is, I encourage every patient, if you have any symptoms and you go to see your primary doctor and you get reassured, if this symptoms doesn't resolve it within a period of time, 2 to 3 weeks, you might need to insist on the primary doctor to get testing you for at least have a blood test to make sure that everything with the liver are going okay or are normal. And basically, if there is any signs or symptoms or indications that there is liver dysfunction, the patient should be referred to a hepatologist immediately. Dr. Gish, please comment.
No, I think these are really good points. So I would say 2 years ago, I only thought about these when I was taking my board test because I didn't know we had genetic testing available. I didn't know how to interpret it. But genetics have changed dramatically in the last 5 years. The time is now. We have lots of reasons why we might have made a late diagnosis 2, 3, 5 years ago. We have no excuse at this time. You don't understand what's going on. It's a cholestatic pattern, genetic test, ask for help. Back to you, Farah.
Yes, one of the other question was that the patient is asking, is biliary diversion is the only permanent solution to PFIC, and is that, what's the difference between that and transplant?
Well, biliary diversion, as a slide with a cartoon, Dr. Gish showed it in his presentation, is basically taking the shortcut and making sure that these harmful bile salts doesn't go back to the liver and increase the intensity of itching or skin irritation. Biliary diversion, it usually works at the beginning, but later on, after a while, the intestine starting to be smarter because our human body is being created by God and in a smart way. So this starting to accommodate the effect of this high bile salts by starting to increasing the absorption of these bile salts.
One of our audience has asked, he's asking, what promising research trials are in process for further development of treatment option for PFIC patients?
There's 3 other medications that are in this IBAT family that are in development. So more of these drugs, and of course, eventually it's going to be genetic engineering, genetic treatment, but I haven't seen anything. Dr. Yanni, do you know of any trials that are going to be using iRNA or antisense or epigenetic modifiers or CRISPR where we might modify genes directly? Have you heard of those?
I heard about those, and actually our own division chief, we blessed with Dr. Rohit Kohli, is a major renowned scientist in the acid bile transporter. He has multi-million-dollar grants at Children's Hospital Los Angeles, running the lab with all these research studies. Nothing yet come out as definite, but the promising new developments, the 2 medication, Livmarli or maraliximab, and the Bylvay are making a major change in the field of this cholestatic liver disease.
Another question, why do some PFIC patients need to rely on feeding tubes for nutrition and fluid and others don't? What's the difference?
The difference is basically a turn back or depends on the type of the PFIC the patient had. As Dr. Gish explained in his presentation, initial discovery for this disease showed there's PFIC 1, PFIC 2, PFIC 3. So usually this disease affect very young babies and young children. The one major difference is PFIC 1 is always associated with diarrhea and failure to thrive, or the baby or the child is not growing well. And sometimes it's very refractory. secondary to multiple factors. The diarrhea is one cause to loss of all the nutrient from the human body. In addition, that's the itching or the pruritus make the quality of life very, very poor. So you have a child who is deprived from sleep. Parents are deprived from sleep. There are ongoing symptoms of diarrhea. So like you find that the nutritional status for this child is commonly poor. And sometime you might need to give them slow feeding by tube. There's a type of PFIC, which is a brand new, one of the newly discovered called PFIC 5, is associated with a disease called microvillus inclusion disease, which mainly affects the intestine, which the people who are affected by this disease, they usually require intestinal transplant because the intestine is not able to absorb any nutrients. So this is why most of these diseases are usually apparent from birth or shortly after birth, and if they are followed up by a good hepatologist or gastroenterologist, they made the choice to give them good nutrition from the beginning.
Dr. Gish? Oh, you're muted.
Mute faster. That's a very excellent explanation there. And every person's different. Each tends to have their own specific profile. And of course, the more aggressive, the worse the disease, more likely we're going to go to transplant. You're going to do IBAT first and then going to transplant. I'm assuming, Dr. Yanni, the biliary diversions are going to be rarely done now that we have IBATs or move to transplant. Is that correct?
Agree, 100%. And we have experience with one of our patients, PFIC 3, who presented to us at age of 7 with failure to thrive, but grade 3 to 4 hepatic fibrosis, almost cirrhosis, portal hypertension. And once we put him on the IBAT, which was Liv Marley, we actually put him right now on status 7 as his liver function test starting to completely reverse. And he's still suffering a little bit from malnutrition, but he all along he is progressing on the right direction.
And we talked, Dr. Yanni, earlier about the difference between liver enzymes and liver function tests, that AST and ALT are not LFTs. So is it both function and enzymes that we're improving?
The synthetic function actually is starting to improve. The INR starting to slightly improve because we're getting hit by the double-edged swords, the liver fibrosis, in addition to malabsorption and the poor nutrition. So combining the effect and relieving the itching make this person starting to have better quality of life, better nutrition, and we are seeing some improvement. We are not out of the woods yet, but we are trying. It's always better to have the native liver. We call it always the best thing to have is a native liver.
Great to preserve that. Nice. Thank you.
The next question is, I am 18 years old. I received my liver transplant because of PFIC when I was 8 years old. My body rejected the transplant twice, and then my small intestine stopped working. Is this a natural course of transplantation for PFIC patients? Do you see many patients like me? Is there any hope for me to get rid of this disease and have a normal life?
May I know that was this patient was transplanted because what type of PFIC he has?
He didn't mention what type, but he was transplanted, he said, when he was 8 years old. So it's 10 years ago he got transplanted.
Well, most commonly we transplant pediatric patient or children with PFIC when, as I just mentioned a few minutes ago, that the liver is totally cirrhotic. The child is developing bad complication or bad consequences of the liver cirrhosis, including portal hypertension, ascites. The most common type which can make the child goes for liver transplant is PFIC2, which is very, very aggressive disease. And this specific type, PFIC2, is characterized by or interested, that's the defect, which is a BSEP, or the bile salt export pump antibody, can come back after the transplant. So the patient has to make sure that the transplant hepatologist he's followed by is getting a test at least once or twice a year on this specific antibody, which we call it anti-BSEP antibodies. Unfortunately, this test doesn't get done here in the United States. It can be done outside of the United States. I have a patient who's from Lebanon who got transplanted for this specific type, and we have been testing, and about 9 years ago he came back for a follow-up, and he had the worst rejection. Usually we almost lost his graft, but with aggressive treatment and manipulation and correcting the manipulating or modifying the immune suppression, we were able to salvage his graft. So the patient need to ask his transplant hepatologist if he can test for this, and also he need to know that the transplant hepatologist has to be expert in treating this rejection with modifying the immune suppression.
Thank you very much. And this is into another question. We have echo. Another question that we have that people are asking is transplant really the final solution for PFIC patients? But the way I heard it, Dr. Yanni, that in PFIC2, that's very aggressive, transplant may not be the final solution because it may come back. PFIC may come back. Am I correct?
Farah, I mean, I'm sorry, I didn't make myself clear. There are so many entities or so many types of liver disease which can be an indication for liver transplant. There is a tendency we say there is a risk for recurrence of the disease, including like people who get transplanted for autoimmune hepatitis. We know that a person who has autoimmune hepatitis, which is a dysfunctional immune system starting to hit the liver and cause complete liver damage, that he went into to have a liver transplant. This patient has to be treated differently from someone who getting transplanted because of the biliary atresia, or transplanted from Alagille syndrome, or from like alpha-1 antitrypsin, because there is a risk for recurrence of the autoimmune in the graft. It doesn't mean that the transplant is not working. The transplant always works. There is a graft survival success about 90%, but it needs to be very closely monitoring. The patient has to be adhering with immune suppression, compliant with taking the medication on time, compliant with following up with a clinic for the blood test, surveillance blood test, surveillance liver biopsy to discover any early rejection, because once rejection, some rejection can present with sudden elevation of the liver enzyme. Some other rejection can be, we call it silent or slowly progressive rejection. And this has to be discovered early.
Without now that I think all right, it's good now. We don't have echo. So far, I think we have gone through PFIC 1, 2, 3, and 5. Are these the only variation of PFIC, or there may be more that we don't know?
There is type 4, which is tight junction protein transport defect, which is very, very low incidence. We transplanted one child in our hospital about 3 or 4 years ago with this type. And again, the whole idea, we don't like to transplant children unless really we need to. So once we know that this liver is not able to support the life of the child, causing more and more deterioration in the general health and causing a risk for this child to suffer from complication, including even death, because they can come with massive bleeding or sepsis or coagulopathy. So we go ahead and transplant them. As Dr. Gish mentioned in his presentation, that if you discover the disease very early and you treat it, you take out the irritating factor or the insulting factor away from the liver. So the risk for more liver cell injury will be coming down, and you will have a chance for this liver to recover and to regenerate.
Dr. Gish, did you want to say something?
So my final comment is that I've been identified, and Dr. Yanni can help support this, that there's 11 different types of PFIC now with 11 different transport defects. But as you go down that list, they become more and more rare. But now that we've got this genetic panel, we can figure out not just that, but their whole family of cholestatic disorders.
I agree, Dr. Gish.
Yeah, thank you. I had a few comments that I just want to kind of give a shout out to mothers, especially who have children with PFIC. We have a young mother, she's 30-something. She has 2 kids with PFIC. Luckily, it's PFIC 1 for both of them. And this third child is completely normal, no symptom of anything. But I want to kind of give a shout out to mothers who take care of PFIC children, stay up all night because the kid cannot sleep. So that was a few of the comments that I had received to say something. I don't know if you want to say something about that, Dr. Yanni and Dr. Gish, about families of the PFIC kids.
Is she followed by a hepatologist or followed by a regular doctor? Because the main questions come into are these children followed by a specialist who know how to deal with this? As Dr. Gish explained, and again I explained, there are 2 new medications on the market. These 2 new medications are wonderful medication on the market, approved for all age group, and they are very, very, very effective in treating the skin itching and improving the quality of life for the children. So they need to know about this, because these 2 children, if they have type 1, we rarely transplant children with type 1 PFIC because like the liver is in general is very, very healthy with intact functions. The only problem is basically continuous itching and irritation and the poor quality of life. So she needs to follow up with her specialist to make sure that are they taking this medication. And right now we have a crossover between the two medication. We have patient like treated with Liv Marley, which is basically initially manufactured to treat itching for kids with Alagille syndrome, and patient treated with Belvay, which is designed to treat kids with PFIC. Now we have cross covering. We have kids failed they Liv Marley on Alagille, and we give them Belvay, and they are doing very well, and vice versa.
Very good. Thank you so much. Okay, so this is the whole time we had. I want to thank everybody for this fantastic round table. I hope you enjoyed it. Please remember, we record these programs and we post them on our website and our YouTube channel. So you can watch it and you can forward it to people you know who are living with PFIC. Thank you, Dr. Gish, for your excellent presentation. Thank you, Dr. Yanni. We know you're extremely busy and we appreciate your continued support of our efforts. I want to thank
you for your, and I hope everybody is doing well, and thanks for the whole Liver Health Foundations.
Thank you. We also thank Epson Pharmaceuticals, so we truly appreciate their support. Now, some of advertising for our own Liver Health Foundation. Please join us on September 21st for Walk for Your Liver Los Angeles in Santa Monica. This is our annual walk in support of liver patients. During the walk, we will feature many liver patients as they share their liver journeys with you from the podium. There will be refreshment for all. Children are welcome to enjoy face painting, music, dancing, and balloons. Please visit our website to register to walk with us. Liver Health Foundation will host a webinar on MASH, which are known to NAFLD and NASH, on June 13th from 5:30 to 6:30 p.m. We thank our sponsor, Madrigal and Global Liver Institute for supporting our efforts. You can register to attend those webinars by visiting our website. On June 20th, Liver Health Foundation will host a special webinar on a rare liver disease known as Wilson disease. Dr. Jeffrey Kahn from Keck School of Medicine will be the presenter at this webinar. We thank Orphalon Pharmaceuticals for supporting this rare disease webinar and hope you can join us. Liver Health Foundation is on all social media sites. We announce our events, program, and the news on our website and social media. So please join us and read about our activities. Thank you to all our audience, our wonderful panelists for joining us this evening for this very important webinar. We hope to see you at our upcoming webinars and Walk for Your Liver Los Angeles. Be well, stay safe. Thank you and good night.